If you've ever looked in the mirror in the past few years or months and thought, I don't feel like myself anymore, today is for you. You're not alone. And more importantly, you're not broken. Um, what your experience is very likely the predictable biological transition that we all go through, but we were simply, never properly taught about. Today, we're going to bring clarity to that transition. And we're going to cover how to identify your menopause phase, what treatment options exist, why personalized care is so important, and a one size fits all just doesn't work, um, and how to find a provider who truly listens. And by the end, you'll have a language, understanding and knowing what your next steps are. So before we talk about treatment, though, and before we talk about options, we would need to answer, the foundational question of what phase are we actually in, because treatment only makes sense when we understand the stage. But before we get into that, I do want to just let you know a little bit about my own personal journey and why this has been so impactful in my life, as well as why I am so passionate about helping women in this phase. So my own journey started a few years back. And I started having a lot of changes in my life, gaining a lot of weight, being pretty irritated all the time for potentially no reason. I don't know. Life is tough. It's hard to know sometimes if people deserve your irritation, but becoming more and more irritated than I ever am as my typical nature. A low level of anxiety, agitation, really having a lot of trouble sleeping, and a lot of brain fog, not as sharp, not as clear. And that was impacting a lot of phases of my life, from work to interpersonal relationships. But all of those things, sometimes it just feels like life. But the tangible thing that sent me to the doctor's office was my blood pressure was going up, and which I'd never had blood pressure problems before. So, but being in healthcare, I knew that that's a problem. You need to address your blood pressure. So, the one thing that I did have on my side was I did think that maybe there's a hormonal piece to this blood pressure thing and why I couldn't sleep. And honestly, that's the only connection I had made. I had cared for women in midlife for years, as a family medicine provider. And that's just, part of your practice, midlife women. And they would come in and I treat them by the guidelines. We have our guidelines and our pathway that we usually follow. And I didn't think much else about it. I thought I was giving good care in this area because I was following, basic guidelines. But I was not able to translate that information to what was happening to me. The only thing that sent me again to the doctor's office was my blood pressure, and I needed to get that handled. And I thought it was related to sleep. So I waited weeks and weeks and weeks for my first appointment with my primary, only to show up and be told that she was uncomfortable in this space. She did not do anything with hormones or testing, or she really couldn't have a conversation with me about it. And to say I was devastated is actually probably an understatement. I left in tears. I'd waited so long for this appointment. I still can't sleep, mind you. And I just left feeling very dismissed and really hopeless. And I want to also mention, I walked into this appointment basically as a contemporary, as a colleague. We care for the same, as in primary care, we cared for the same type of people. I went in there, I thought very able to advocate for myself, and I was completely dismissed. So I ended up with going to see an OBGYN, because isn't that who is supposed to take care of midlife women, or all women, I should say. And she had a couple of minutes for me, said basically, here, take this medicine, and I'll see you in a year. I did take that. It was hormones, and I later found out nobody prescribes that anymore. Who actually is current with this care. But you know what? I did feel a little bit better. So, and then I ended up with a very prestigious Stanford OBGYN because I thought, I don't think I'm getting good care here. So I went to her, and she absolutely, she had a couple of minutes again, and she had a one size fits all approach. She switched things up a little bit and absolutely would not speak to me about anything else. So I said, well, how about this? What about that? Let's talk about this. She completely shut me down. And I left again, feeling, I did get a little bit of help. So I was feeling a little better, but I was completely dismissed. So that's when I got the fire lit under me that I really needed to understand more about this. And I got more and more educated. I became certified. I took classes. I went to conferences. I read every study I could read. And then I ended up with my current PCP, who is absolutely amazing. Couldn't speak more highly about her. But she willingly and upfront said she really didn't know much about this part of medicine. But the thing was she was really open to learning. So together, her and I came up with my current plan that I has just completely changed my life. So that was a long-winded conversation or explanation to let you know, I have been there. My perimenopausal symptoms were really devastating, and I actually didn't realize how much they had impacted me until I got to the other side. I didn't realize all of the moody things, the weight gain, the brain fog, as the lights came back on and the fog lifted and I had that joy back in my life. It was so overwhelming how much my life had been impacted by this loss of hormones and hormonal chaos in perimenopause. So I have walked in those shoes, and I now have made this my life's mission to help women get educated and find the help that they are looking for, and so that's how I created Thrive Midlife Medicine, where we only take care of midlife and menopausal women. And the hormone care and all the other options that are available. So that is my story. I just wanted to set that stage. And so with that, I say let's get started. Let's see. Okay, so I started off mentioning that the stages. We need to understand the stages to know what the next steps are. Where am I, and what's going on, and what kind of help I can get. So, and let's see. Struggling with my slides. Okay, but before we get started, I do need to mention this boring but important piece that this presentation is for educational and informational purposes only and is not intended as medical advice. The information shared today should not replace individualized evaluation, diagnosis, or treatment from a licensed healthcare provider. Always consult your qualified medical professional regarding your own specific health concerns. So I am a licensed provider, but I am not your licensed provider. So we will move that piece over. Okay, so and then why does this matter? Well, because menopause and perimenopause, it isn't just hot flashes. It affects nearly every system in our bodies. And that's why we need more than quick appointments and a lab value. So menopause and perimenopause, it can significantly impact our sleep, our mood, brain function, metabolism, bone health, long-term bone health, our sexual health, and our long-term cardiovascular health. Again, when I talk to women about going into this transition of life, I like to talk about it in two buckets. One is symptom management. Women, we want to feel better. We want to feel like ourselves again. We want all of these, symptoms to be managed and or completely, knocked out. But we also need to look under the other umbrella, which is our long-term health and our hormonal chaos and hormonal depletion significantly plays a part in our long-term bone health, brain health, cardiovascular health. So that is why this is so important. And so with that, where do we start? Well, we start with identifying our phase, and it is not just about labs. In fact, labs have very little value as we start into going into some hormonal changes. But also, I'd like to say that hormones are not the cause of everything that's changing, and they're not the cure for everything. So while checking labs as far as our hormones are not that impactful and do not guide care as we start into this stage, there can always be more than one thing going on at a time. So looking at other hormones, other cardiometabolic markers to see if something else is happening, checking thyroid, checking how our blood sugars are doing, checking comprehensive metabolic panels and other things like that. So while labs don't direct the hormonal care, they do have to be done as a baseline to make sure we're dialing everything in. So this is where we start. So this is the hormonal timeline, and perimenopause can begin 5 to 10 years before a woman's final period. So it needs to be thought of as a transition. It's not an event. I know as I was coming up, there was kind of this, pre-menopausal, this thing happens to you, and now you're postmenopausal. But little knowledge and understanding of this transition, which is incredibly impactful. For some women, it is just slow transition, gentle, manageable. And some women, it's incredibly abrupt and very dysregulating and very disruptive. I know for myself, it was kind of those, it happened slowly and then all at once. Sometimes everything converges on you at once before you go, oh my gosh, I have a problem. So the hormonal timeline, we have our reproductive years, and then as our ovaries are kind of wearing out, we start into early menopause. We're starting to see changes. We then have late perimenopause, menopause, which is, once your periods have stopped for 12 months, and then postmenopause. So let's talk about each one of those stages a little bit more. So early menopause, this can happen as early as a woman's 30s, mid 30s, late 30s. I have several women in their mid 30s, and I actually have a handful that are in their early 30s that are starting to go through obvious hormonal changes with significant symptoms. So in early menopause, this is when estrogen is fluctuating wildly, but cycles can still look normal. If you're regular as far as flow goes, because a lot of this, that's kind of our first sign is what's happening with our periods. But we are starting to feel different. And this is often when women are told that everything's fine, your labs are fine, but the experience, oops, I'm getting an echo. Oh no, I don't want to torture you guys with the sound. Emily, is the sound okay?
It sounds okay for me.
Okay.
So is everyone else, if you could put in the Q&A if you're having any sound issues, that would be helpful, everyone. Or maybe just raise hand if there's a sound issue. Sound is good, Megan says.
Okay,
Okay.
awesome.
If there's any problems, just throw it in the Q&A and we'll figure it out.
Okay, thank
Okay,
you.
thanks
Thank
everybody.
you, Emily, so much. Okay, so back to early perimenopause. So cycles are still probably regular, but maybe PMS, if that was an issue in the past, that's getting worse. Tenderness, again, if that had been an issue, as the cycles change, that can be impactful and like, that's worse. Sleep changes, very, very, very common. Maybe even if the cycles are still regular, they can start to become heavier. Sometimes they are, sometimes they aren't. Increased anxiety is a really, really common symptom, especially in this stage, and it's not measurable. So, it's hard to sometimes quantify or is this life or something else happening? So these are subtle early signs. Um, but these are the most common. So this is early menopause as the estrogen is starting to fluctuate. And then we move into late perimenopause, and this is really when hormonal chaos peaks. This is not our levels are rapidly declining. Actually, what's happening during this stage is estrogen very specifically is surging and crashing, and these dramatic highs and lows are incredibly difficult for our brains specifically, and then the rest of our system. So during this time, the estrogen is wildly fluctuating, but progesterone is really declining significantly, which is why in this stage, sleep is probably the most common symptom that is challenging for women because of the progesterone, which is so impactful in our sleep. So, the most common symptoms you see on the screen, cycles really can start changing. They might not, but that can be an early sign. They're lighter, the interval is different, or they can be really heavy. Changes in that way. Mood swings are a big part of this stage, where whether tearful, angry, uh, irritated at everything or nothing. Rage and irritability, that is so disconcerting for women, especially, when we've been so level and even and go with the flow. And all of a sudden there's this underlying rage, getting very upset. Not everybody, but this is so, so common. So I wanted to include it here. Brain fog is real. That can be related to the hormonal chaos, and of course, there also you can't deny a component of problems with sleeping. If we can't sleep, we can't think. So, night sweats. That is our estrogen changing. And hot flashes, night sweats, which by the way are different, but they are an indicator of what's happening to our cardiovascular system. So as it can seem like a superficial symptom that we are suffering with, but it actually is an indicator of what's happening to our cardiovascular system. So the night sweats and the sleep problems, and you're waking up in the middle of the night, 2 o'clock, 3 o'clock every night, cannot get back to sleep. That is late perimenopause. And as you can see, those are really significant symptoms that can just really impact every part of our lives. Um, and again, time frame that can last for years. So the next stage, of course, we have to talk about menopause, which is it's not a day. It is a transition. Well, actually, let me rephrase that. Actually, it is kind of a day. So we start having changes in our. Sorry, I'm having some. I got to move this over. I can't see my own screen. What's happening? Okay, oops. Sorry, you guys. Okay, having troubles. I am not tech savvy. All right, so defining menopause. So it's officially diagnosed when we've gone 12 consecutive months without a menstrual period. So that's 12 months. And women will regularly say, I was at 6 months, I was at 11 months, and then it came back again. So you are not in menopause yet. So it's the full 12 consecutive months. And then during this time, that is when estrogen levels are consistently low. And this is what marks a really significant shift for us. And the symptoms that you can experience are from they move from being caused by fluctuations, that wild swing back and forth, to depletion. Depletion. And these changes are crucial in understanding what your body is actually experiencing. The depletion. So remember, each stage of menopause, it brings unique changes, and understanding them can help us better manage our health. So with that said, let's look at now what. So this is when we start saying, okay, where do labs fit in? So we were speaking earlier that labs are impactful for, assessing what's going on, but really not driving pre-menopausal care. But they're more impactful in the menopausal stage. So why they don't tell the whole story? It's again different pre and post. So when you do the hormonal labs while you're still getting a cycle, that's just one day. It just tells what's happening that day. And now that's a different conversation once periods have stopped for 12 months, because then things are kind of, that depletion is stabilized. So that conversation and those lab values have a different impact in the care. Less so for driving the actual plan of care, but they are incredibly impactful for getting a baseline, then knowing if the care that's being delivered is effective or not. So just to reiterate that the estrogen specifically is fluctuating a lot pre. FSH is also changing before actual menopause starts, and then becomes more consistent after actual menopause. So again, symptoms. That is anybody who really is providing the best kind of care, evidence-based care, will treat you based on your symptoms. And perimenopause is not diagnosed from lab values. We diagnose it based on patterns and symptoms, and your story is actually the data that we use. So moving on. So treatment options, and they can vary based on what phase of this journey that you're in. So early perimenopause, the goal in this stage is to calm the nervous system and smooth out those hormonal fluctuations. So the highest priority and the focus, as far as from a clinical perspective, but it's absolutely informed by where a woman's at and what is really being the most impactful in her life. So sleep optimization is usually one of the higher priorities, because it can impact everything else in our life. And that often is led by looking at progesterone and supporting a woman in that way. So progesterone is usually a good conversation piece in this stabilization phase. Stress physiology support, of course, very impactful. Regulating the cycles as much as we can or need to, that would be a focus during this stage. And then, of course, a foundational piece, no matter where you are, is proper nutrition and moving your body in the best way that you can for the stage that you're in. I do like to point out that while looking at hormones, looking further upstream of what can potentially be impacting a woman's symptoms, that is, imperative. But the foundations of eating really well, trying to sleep, prioritizing sleep, and moving your body every day, which of course I think strength training is a huge piece of that, and it becomes even a bigger piece as you go along in this journey to maintain your muscle mass and maybe even grow a little bit more. So we look at all of those things in early perimenopause. The goal is to stabilize, and the goal is to calm the nervous system and smooth the fluctuations. So moving along into late perimenopause. This is when women need more structured intervention typically. This is the time of the greatest chaos for most women. And so we're looking at ways to manage symptoms, support her in that way. And then also back to those two umbrellas, manage symptoms and protect long-term health. So this is when we start really taking a potentially different approach. And this is where care might change, is we can start talking about a more advanced level of hormone therapy, which of course is highly individualized. There is, again, symptoms and long-term health. So there's hormone therapy, there's non-hormonal medications, pharmaceutical medications. There's vaginal estrogen, as we have some physiologic and sexual changes, mood and sleep treatment, and metabolic support. Okay, so then once there's 12 months with no cycle and we've moved officially into menopause, the goal is to replace deficiencies, and as we need to, and as we want to. It's every woman's right to decide exactly how she wants to manage this, and then protecting our long-term health. Again, bone health, brain health, cardiovascular health. So what that can look like is looking at systemic estrogen, if a woman is a candidate for that, and most women are. We'll get into misconceptions later. Progesterone support. So I added in here that it's a must if a uterus is present. And I want to just take a second during this slide to talk about that, because that's an area of a lot of confusion for women and for providers, by the way, that are not really up to speed in this specialty. So systemic estrogen can look like patches and gels and creams and vaginal inserts and maybe even oral medications. And so lots of delivery forms for that. And then there's progesterone. So there is a wide misconception that progesterone, you only have to take it to protect your uterus if you have one still. And, to balance the estrogen, which then protects the endometrial lining. That is true. When you look at progesterone and progestins, that they have a utilitarian function of balancing estrogen and protecting the uterus. But that is just one of their purposes. If you are looking at bioidentical hormones, which we can talk about that later, which is always a place I like to start whenever possible. We have one progesterone that actually, besides that utilitarian function of protecting the uterus, it also can have these amazing benefits on our GABA receptors of our brain, which that's sleep and mood and anxiety and this incredible sense of calm. So even if a woman does not have a uterus, I regularly consider adding progesterone, and I hope the women look at that as well, because it can also be incredibly impactful for all of those other symptoms. And even without a uterus, a woman can absolutely use progesterone. So I wanted to make sure I point that out just in case I miss it later. It just comes up so often and it's so misunderstood. And then there's testosterone. Testosterone, again, very misunderstood. Absolutely a big piece of this puzzle. So testosterone, we often think of it for men. Testosterone is for men and estrogen is for women. No, both genders have a significant amount of each. I like to point out this fun fact that when a woman's ovaries are functioning fully, that typically we have about 4 times as much testosterone circulating as we do estrogen. So that always takes women off guard, but it's true. Testosterone is incredibly impactful. So, but with that said, not every woman wants to look at supporting testosterone levels and they don't necessarily have to. But I always like to have that as part of the potential care plan if indeed a woman wants to trial that and see what it can do for her. And then again, we have I have the bone, brain, and cardiovascular protection because we are looking at feeling better as well as our long-term health. So um, we will get into all of that a little bit more later. But I also don't want to get too far down the rabbit hole of very specific details about all of these hormones. I just like to give a high level view of kind of what they do, why they're so important, and to get us thinking about having those conversations and considering what our options are. So we have that hormone replacement piece, and then there's also non-hormonal options. And this is really important because not everyone is a candidate for hormones, or I should say all of the hormones. And not everybody wants hormone replacement, and that is okay. It is a woman's, this is her body and her choice. And but with that said, there are plenty of other options. So for management of symptoms, there are options like SSRIs and SNRIs. Those basically are antidepressants, and those are kind of often when women would appear at their doctor's office, with this constellation of symptoms, sometimes antidepressants would be the first thing that was handed out. And while we know better now that is not first line, that's not necessarily what kind of the guidelines show in some of our, old school guidelines. So that is often what's offered a woman, and it doesn't mean that maybe she doesn't need one, but I just like to point that out that we just because we're having mood changes and anxiety and depression and all these things, we don't necessarily need these antidepressants, but they can be really impactful if a woman opts not to look at hormones and just needs symptom management. So antidepressants, gabapentin, which is basically, we think of that one as a nerve pain medication, but it can be really impactful for hot flashes. Veoza is the next one. That is also a non-hormonal option for hot flashes. Cognitive behavioral therapy with or without hormonal replacement therapy it has a lot of evidence behind it that can help with symptoms. And then, of course, lifestyle medications. This is back to foundational pieces that we all should get dialed in. But if you're going to opt for the non-hormonal route, this would be more significant and need additional optimization and focus. So lots of options for women who either can't take hormones or don't want to. And with that said, I do want to point out that this isn't usually for most women actually, I'm going to go on a limb and say all women. It's not a one or the other. So let's say a woman has some significant medical history that limits her hormone replacement options. That doesn't mean everything is off the menu for her. That just means maybe the risk-benefit analysis for one of the hormones is a different conversation, but there are other options. So I always want to point that out because when we hear hormone replacement, I think the general layperson thinks estrogen. And but we know now we're talking about estrogen, progesterone, testosterone, and just because estrogen might have a different risk benefit analysis, it doesn't mean the other ones are off the table. So it can be care can look like a combination of one or more hormones and then one or more non-hormonal options. So not to confuse things, I just want to point that out. Moving on, why one size fits all is it just fails and it never should be the path anyone takes. And the reason is because this journey is really individual. Women will present with different presentations. So different symptoms, different medical history, different genetics, stress history. We know a lot about stress and trauma going into this phase of life can be very, very impactful, and different having different goals. You know, I don't want to belabor that too much, but not everybody has the same goal, and that is okay. And that's why care should be very individualized. So some women sleep. They struggle the most with sleep, and that's what they need to focus on, and that's okay. And others, it's the mood changes. There can be a significant component of muscle, joint, body pain, and that might be the presenting thing that sends her, to her doctor's office. So we don't treat the symptoms in isolation anymore, or if you're giving good care, we hopefully, if you're with a specialist, we look at them as under this umbrella of hormonal changes and focus first on what is the most pressing presenting concern, and then how does your own personal assessment of your history and your uh, um, goals, how is that impacted? So these are the usual predominant symptom clusters. So sleep and that everything that falls under that can be the biggest symptom cluster. Mood might be the most dominant concern or the biggest changes that are happening to you. Metabolic dominant. Now that is a little bit broader, so that can look like the weight changes, which they're real, they're very real. You are doing everything the same, you're eating the same, you're exercising the same, and you're still gaining weight, specifically in your midsection. And that we can see it. So it's often thought of as an aesthetic thing. But of course, I don't need to point out that when we have excess adipose tissue on our bodies, that actually significantly can impact our health, increase risk for cancer, and those things. And then sometimes it's the genitourinary symptoms that will drive a woman to get care. And that can be changes in sexual function, dryness, trouble with lubrication, difficulty or changes in arousal. So sexual function, but also the urinary tract can be significantly impacted during this time and what's happening is there's a pH change in the genital urinary system. So the urinary system changes can look like urgency, frequency, getting up in the middle of the night to pee more than usual, leaking, UTIs, bladder irritation. So that can be really impactful. Itching, pain, yeah, things like that. So those are the main symptom clusters. And why the cookie cutter approach just doesn't work. So we talked a little bit about the different presenting ways a woman can present. So if she's presenting different, obviously her care is going to be different, at least if you understand all of the options available to you. So and then something else to recognize is we're all individuals. So, the same dose for me may not have the same response as someone else. A different route, a different dose, different formulation, a different combination of hormones. So, the reason that the dose and the response do not correlate is we potentially could absorb differently. Our risk profiles might be different and likely are, and our own personal preference. Back to personal preference. This is supposed to be a team event. We decide together what we're going to do. So cookie cutter is just poor care. I'm just going to say it. It's poor care. So and with that said, though, personalized care, it's not boutique medicine. It's good medicine from somebody who understands the evidence and is providing, the highest level of care possible. So now let's talk about how am I going to get to that person, the good care, the personalized care. Um, I like to point out things for you to look at, red flags, green flags when you show up at your provider's office, whether that is your trusted primary care provider, your GP, family medicine. Maybe you've determined I'm going straight to a potential specialist. Maybe that is your trusted GYN. Um, and these are red flags that make you think maybe I'm not in the right place, and maybe you are, but just to get you to notice. So the biggest red flags I think are running labs and saying, "Well, your labs are normal. It's not that." Well, we've already talked about when you're in perimenopause, your labs can absolutely look normal. It doesn't mean you're not suffering, and it doesn't mean things are not changing. The same with you're too young. That is that is so common. It is very disconcerting. No, you're not in your, fill in the arbitrary age. No, you're not in your 40s. You're not in your 50s. You haven't gone, 12 months without a period. That is one of the most dismissive things that I hear from the women that come see me after they've been dismissed. You're too old. We have so much science that tells us that is not true. Now, if you are significantly past menopause, 10 plus years, that's a little bit different conversation, but you are not too old. It just means it's a different conversation. Maybe the risk benefit analysis is a little bit different, and maybe the options available to you related to that risk benefit analysis are a little bit different. But again, that is shared decision making, and there are absolutely options. You are never too old. And here's the one that just gives me such heartburn. This is just aging. This is just normal aging. Yes, we are we are aging, but suffering does not have to be part of that. And protecting our long-term health also is part of this conversation. So that's just aging is really, oh, that gets me going. And then not having a follow-up plan. Okay, so we've decided we are not going to address my concerns today. What are we going to do? That any of these things that you see on the screen, those are red flags. Maybe you can continue the conversation, or maybe you need to go somewhere else. But these are the biggies. And if you've heard these phrases, I'm really sorry. There is help and hope out there, but moving on, let's get back to the hopeful part of this conversation about green flags. So these are some things that you know that you're probably in the right place. If your provider is talking to you about your symptoms, and this even postmenopausal symptoms really should be driving your care, in my expert opinion, and having a thorough risk discussion, but that risk and benefit, I like to point that out. Again, we've got symptom management, and we've got our long-term health management, and that's part of the benefit discussion. And there's risks of not treating our long-term health. So risk benefit discussion, shared decision making. I cannot say this enough. This is not your provider's personal opinion, their personal bias. You need to know what your options are, and together you will decide what the next best step is. It is your body, and you are 50-50 in this equation. Shared decision making always, and having a follow-up plan. How are we going to assess response, efficacy, maybe follow the labs at this stage and make sure everything is the way it's supposed to be. And of course, all of this falls under the umbrella of respect. When there is that basic respect for your patient as part of this equation, then that allows these amazing conversations to take place. And so you deserve a partner, not to be dismissed. So another thing I like to point out is either how to find somebody to be part of this care team or to know if you're in the right place is to ask a couple of basic questions. So you can ask, what training do you have in menopause? That is okay to ask. I love to say to people, because I think sometimes they're surprised, especially in family medicine, we cannot know everything about everything. And that's okay. And it's good to know that you don't know everything about everything. So asking this question, do you have any training in menopause? So there is, we do know that even with GYNs, 80% of GYNs have had no training in their medical school residency. So 1 in 5 have, and even if they have had some training in menopause, it's usually very, very minimal. So knowing that, you can. None of this is to say somebody is not trained and not competent, but it's just, I don't think people recognize that or know that. So I always like to point that out. Now, that's not to say that there aren't amazing family medicine providers and amazing GYNs, but I can guarantee you they have sought out additional training, additional certification to get that expertise like I have. It's just not part of the curriculum. And so pointing that out, and then asking them, do you individualize? How do you do that? And having them explain. Again, these are questions you can absolutely ask. And I hope that by the end of this presentation, you have that feel empowered to recognize your own part of the care team. Sometimes it's hard to go into the doctor's office and kind of sit there as part of the team and not just kind of do what they say. So how do you individualize care? What is my own risk benefit analysis based on my history and my goals? And then how am I going to measure my care? How are we going to follow up on the care? How do I know things are going in the right way? So advocating for yourself absolutely begins with better questions. And it's because you deserve it. We're at an amazing place right now in healthcare where this part of a woman's life is being discussed. The conversations are getting louder, and so we know that we do deserve clarity of what's happening, clarity on what our options are, based on our own personal health and risk benefit analysis. We deserve to be treated as a partner in our healthcare and treated by the evidence. Evidence-based is my baseline, bottom line. We need to have good evidence of what we're doing. So with that part said, this is where Thrive Midlife Medicine comes in. Why are we different? We are different because these are my core values: to treat every woman as an individual, to be her partner in this, and to make these decisions based on what resonates with her, what her goals are, and it's not a one-way street. When there is good follow-up and a good provider-patient relationship, we can switch gears. We can do new things as new symptoms come. We can change. There's lots of options. So another piece of why we're different, or why I think we're head and shoulders above, is the time that is spent taking that deep dive into what is happening and doing such a deep assessment to really have precision care options delivered. The other piece that makes us different is making the care accessible. So most providers in this space that are specialized, they are working on a cash-based business model. The vast majority, whether they're a small, private practice, or they're, maybe a big telehealth platform. And while I do understand why this is the most common practice model, um, the constraints of insurance on providers is significant. So I understand why folks don't want to be part of that process. But okay, then what happens if you can't pay for, concierge medicine and pay out of pocket for a specialist? So I felt compelled and that I had to provide insurance-based care, so all of those other women are not left out. So this slide just shows we have contracts in place with, as you can see, the some of the, I think they are actually the biggest healthcare insurance companies. We're rapidly expanding, moving into more insurance contracts, as well as moving into more states. Currently serving women in California and Nevada, and quickly expanding into into the other eastern states. But with that said, maybe unfortunately you have an insurance company that is not part of our network at this stage. So then there's other options. There's always self-pay, and a lot of women choose self-pay even if they have insurance, and for lots of reasons. And so that's absolutely an option. Sometimes they have high deductibles and things like that, and that's part of it. And they can always use their HSA, FSA account. But if your insurance company is not listed here, there, and you're considered, out of network, then what is typically done with any specialist is a super bill is provided. So then that is submitted to the insurance company, and then they reimburse you for your medical appointment. Another thing I do like to point out is I believe in, as much as possible, using FDA approved, evidence-based medications if that is an option a woman decides on. And the reason for that is a couple of things, because there's a lot of different ways to have hormones delivered. They can be from a compounding pharmacy, they can be from pellets, they can be from things like that, but none of those are FDA approved, which means and it doesn't mean they're bad, it's just a different conversation, but it just means they are not covered by insurance. So because one of my highest priorities is affordable access to very specialized care, I do like to stick with FDA approved, insurance covered hormones or non-hormonal options whenever possible. And then, for Thrive Midlife Medicine, if what we're talking about today resonates with you, there's a couple of ways to reach out to us. If you still had some questions about the process or philosophy or how the care is delivered, I do offer at this stage some limited 15-minute free consultations. Those do not involve, specific care plans or very specific medical questions, but it is a time to see if our practice is in alignment with what you're looking for and what your goals are, and just do a vibe check, see if we fit, and then of course if you're excited about starting treatment and you're ready to dive right in and start feeling like yourself again, the next step would be to sign up for a new patient visit. So that is a very comprehensive visit. It's 60 minutes, and then even before that there's a very comprehensive intake form. So we come into that appointment together with a firm foundation of where you've been, what's happening now, so we can dive right into next steps. And then we come up with your personalized plan. So the QR code there can take you right to our website. You can also email any questions, and the team, which they're fabulous. We get back to folks right away. So I'm looking at the time, Emily. I was going to bring up, I know we have a Q&A session, but I was also going to bring up a couple of the most common misconceptions and the biggest questions I typically get. How are we doing on time? Should we go with these common questions, or should we jump right into the chat questions?
I think let's jump into the chat questions. We have some really good ones and really, I think, very helpful for everyone.
Okay.
Okay, so first one is going to be, I'm just going to put this out there because I think that probably a lot of women have felt like this at times or may feel like this right now, which is this all feels a little bit hopeless. And, if you could speak to that a bit.
Okay, so that could be answered several ways, I think. So a couple of things. When I hear that, not knowing exactly what the question is the piece that's speaking to. So this feels hopeless. I hear women feel in this stage of life that they're looking down the barrel of deterioration, irrelevancy, body falling apart, mind falling apart, maybe their relationships are falling apart, and just this slow slide into just a life that's very different than what they have experienced. And I understand that, and a lot of women feel that way, and I think that's based on the way we've managed women in their post-reproductive years before. But I am here to tell you that that is not the case. We do not need to slide into deterioration and irrelevancy. I see every day in my practice that women come in feeling this way, and they get the help that they are looking for that aligns with their goals. And when they come out the other side, and feeling better can happen so fast, it's shocking. Sometimes the next day, it's like the lights come back on. And I know for myself, and I know we're all different, but for myself, the difference between before I got treatment and after I got treatment, it's like night and day. And it was like the lights came on, the color came back to my life, the zest for my life came back. And I see this in my women to some degree, almost all my women. So that piece of the hopelessness, I hope I'm addressing that. And then the other piece is, maybe this is what you mean. This is so confusing. I go on social media and consume it like everybody else, and it seems really complicated. I got to take this supplement, and I've got to do this at this time, and eat this way, and lift these heavy weights, and wear this weight vest, and get these lab tests, and do all this stuff. And I think it's incredibly overwhelming. And it's not to say that all of those pieces of the puzzle aren't amazing and can really manage your life, but it can be incredibly overwhelming. So it's like, if I can help women just know where to start, just start with the basics, start feeling better, start, having your mind work the way it did before, your emotions, your body starting to function again. And then you feel like yourself, and now let's take it to the next level. And some women can do that really, really fast and just start stacking on these fabulous habits. And some women are just like, I'm overwhelmed. I just want to feel better. So, I don't know if there's even an additional part of the hopelessness question, but those are the two pieces I see every day, and I hope I've touched on those and take away some of those hopeless feelings.
Beautiful. Thank you. So if someone had a partial hysterectomy and only has ovaries, how would they determine what phase they are in?
Okay. That can lead to a lot of confusion. But this goes back to kind of that old thinking, at least on providers' parts, is we're guiding everything by, are we having a period? Well, I'm not having a period. I don't have a uterus. So, so there's two ways to look at it. One is, do you have these symptoms, or potentially are these symptoms related to hormonal levels? Possibly. And again, a good specialist who is up on the current research and the highest level of care is going to treat your symptoms, or looking upstream, seeing if hormonal, if we can do something with the hormones and get you feeling better that way. And Because remember, if you aren't having a period or haven't stopped your periods, best care is to treat symptoms. Now, and the care may or may not change if you were technically in menopause, but we do have tests. That is something that we can absolutely determine. Are you actually in menopause yet? Because, of course, if you're not getting your period, how do you know for sure? Again, it probably isn't going to change your plan of care, but I know most of my ladies like to know, like, am I in menopause yet? Um, so that is one piece of this. And then just to point out, and hopefully this isn't getting too much in the weeds. If women who've had hysterectomies but still have their ovaries were not told this, we don't understand exactly the mechanism of action for this, but when a woman does have a hysterectomy, even if she retains her ovaries, they are going to basically wear out faster and speed up that menopausal transition faster. So a good specialist is going to treat you based on your symptoms and not where you are in the menopause, the actual period part of the journey.
So helpful. Okay. Um, do you have a PPO or are you in network with any HMOs?
Ah, so PPO is for folks who don't know, PPO is where you have a larger system. Or let me say it the other way around. HMO is a closed system. You have to be part of that group. And I think one of the biggest ones we think of, for instance, in California is like Kaiser, is you only can see people in that group as far as having it be covered, a covered visit. And then PPO has a broader, usually they have tiers, first tier specialist that maybe has like the lowest copay and the best coverage, and then higher copay and a little bit more limited reimbursement from the insurance company. So we PPO is the most common insurance, and it's the wow. I'm not an insurance person, can you tell? We do have contracts with the largest insurance companies, and typically it's more the PPO concept. So, for instance, Kaiser is. I'm not a Kaiser provider, so but this is kind of interesting, and it is becoming a bigger and bigger part of my practice. And I just want to point it out here. Hopefully, I have time. Um, I have been having more and more women come to me who are within a closed system and or have a really trusted family medicine provider or trusted GYN that they kind of want to keep their care in one place, or they have to keep their care in one place, because the HMO piece. And but they're not with somebody who really is, knows how to manage this. And so what I've been seeing more and more is coming to me, having that initial deep consultation, and then with the intention of just seeing me the one time, I create, we do the assessment. I create the best care plan possible, complete with this is what I do, this is the dose, this is the cadence of adding and assessing. These are the labs you need to order. This is what you need to look at. And then they are taking this care plan to their beloved, trusted care team to then carry out my plan of care. And I think that's great. I think that's fabulous. And I actually completely support that. I like to laugh that we don't get paid for writing prescriptions. We don't get paid for ordering labs. So I would love for a woman to stay with me throughout this entire journey, but my highest priority is for women to get this education, to know what their options are, and to then get the care that they need. So if that means I'm guiding the care as a specialist, I'm guiding their provider, I'm okay with that. So that was so long-winded. If somebody is in an HMO situation, they can always be a cash patient, a super bill patient, or I can help guide their trusted care team.
Beautiful. Thank you. Okay, next one is, does the type of menopause matter? For example, forced menopause versus naturally occurring?
That is a great question. Let me answer it two ways. One is forced menopause or typically surgical menopause. That needs to be addressed immediately. That is um, potentially devastating if hormones are not addressed alongside of the surgical menopause, or maybe some cancer treatments can shut things down too, and different things like that. So that needs to be part of that plan. And honestly, I can't tell you how many women have come to me and nobody ever talked to them about it, with devastating results. So with that said, that needs to be part of the plan, and it's not always part of the plan, but that needs to be immediate. You really can't wait until everything crashes, because it will be dramatic and it will be devastating. Then with that said, the actual treatment is not going to be different. The actual options based on your own personal, risk benefit analysis, those options will be the same. Typically, unless we're talking about certain very, very specific cancer treatments. And that doesn't mean you don't have options. That just means it's a little bit more nuanced conversation. But forced or surgical menopause versus natural menopause, the actual care should not be different.
Okay, interesting. My OBGYN told me that birth control pills have more hormones than HRT, so I'm covered, but I still have all of these symptoms that are making life really difficult. Are birth control pills a substitute for HRT?
Okay, another nuanced question. So without going too off in the weeds, okay, first thing, birth control pills, they are quite high dose. They are always synthetic. So the actual molecules will potentially and/or definitively behave differently in our bodies. It's a different delivery form. And so typically, birth control pills are oral. And so there's that piece of the puzzle. They can be actually an option at a certain stage, like say a woman is perimenopausal. Maybe she still needs contraception. There's certain disorders related to hormonal changes, PMS, PMDD, where maybe birth control is the first thing potentially to look at least to stabilize things. But it's not necessarily a substitute. It's just a different option. And more often than not, I recommend a woman look at bioidentical hormones as a potential alternative. Again, though, they're much, much lower doses than birth control pills. They will not protect against pregnancy. So if a woman still has sperm in her life, that needs to be considered. But they're delivered differently. So depending on a woman's risk benefit profile, they might actually be much, much, much better for her. Also, now we're talking synthetic versus bioidentical progesterone, which behaves very different in the body. So this is where a very skilled specialist should do a proper assessment. But it's not a substitute, but it is kind of a subset, and they are distinctly different.
Okay, helpful. Uh, let's see. I have a more of a comment, but Veoza is life-saving, but it is very expensive. And yeah,
Okay.
any comments on
Yes.
that?
Yeah. So for folks who don't know what Veoza is, that is a non-hormonal FDA-approved pharmaceutical for basically for hot flashes.
Okay.
So if a woman can't take menopausal hormone replacement therapy, or doesn't want to, or a combination of the two, that is an option for symptom relief. And yes, insurance doesn't protect long-term health, but it can help with the symptoms today. And that is a legitimate, as you know, if you're using it and it's a lifesaver. But insurance coverage varies, of course, by insurance provider, and sometimes when a woman has to try alternatives first before insurance will give the proper coverage. But I think this is a perfect segue into, again, having somebody who really specializes in this space, understanding how insurance companies pay for or do or don't pay for our pharmaceutical options. So if you are going through and this, I don't know if this is your situation, but I just like to point this out because this is a really great question that can speak to a lot of different pharmaceutical options. There are so many different ways to get your prescriptions. Sometimes when you go through your insurance, and they have varying levels of coverage, that is that is a different reimbursement than, say, cash pay, using a GoodRx coupon, using different pharmacies. There's some incredible mail order pharmacies that use all the same medications, but it's cash pay with very, very tiny markup. And sometimes, not sometimes, but quite often, those cash pay options are cheaper than most people's copays. So don't lose hope if this medication or whatever medication we're talking about is a lifesaver. Take a little bit deeper dive and see if there's a better option to get it, or work with your insurance. But there's a lot of different ways to get these medications, with or without insurance, that are more cost effective.
Oh, that's so helpful. Great. Along those same lines, what is the cost of HRT on top of the fee for working with you with Thrive Midlife?
So I, again, prefer, whenever possible, to start with FDA approved, insurance covered medications. So I don't I don't dispense any medications. What I would do is, after we decide the plan of care, shared decision making, I just send the prescription to your trusted pharmacy. And then, however your medications are covered, whether you, want to do cash pay or you have your insurance cover your medications, it's just like any other doctor's visit, where we send your medication to just to the pharmacy, and then you go pick it up like anywhere else. I don't provide the actual prescription, so that follows the regular medical model. So the additional cost is just whatever how your insurance covers it.
Okay. We have, where do supplements fit in? I see so many recommendations in all the Facebook groups I'm in trying to figure out menopause.
Supplements, they have a place. I'm not a huge supplement person. Again focus on the foundational pieces first. With that said, though, I do think there are some really great supplements. I just don't want to overcomplicate things. So there are some incredible supplements. A multivitamin. If sleep is an issue, I'm a huge fan of magnesium, ashwagandha. There's different delivery forms. So, but I don't want to go off into the weeds. It's a few things to protect and support our cardiometabolic health. Um, so while I don't ever want to overload someone with supplements, there's a place for them. With that said, supplements, I don't care how amazing they are, they will never replace your waning hormones. So you need to know that if somebody is promising you that this supplement is going to, be the equivalent of hormone replacement therapy or help you, get more estrogen or whatever, you need to be skeptical. Also look at the source. Is that person selling the supplements? And there's a financial component to it. So, look at everything with a critical view, but there are some great supplements. We don't need a ton of supplements, and start with the basics. And I know it's overwhelming out there with all the stuff we're supposed to do, but start with the basics, feel great. And then there's some really good supplements you could add on to kind of be the cherry on top.
That's so helpful. I think so often it feels like, well, I should start with supplements and see if that takes care of it, and then go to the next step. And what you're saying is reverse that thinking.
Yes, thank you for saying that. I hear that actually a lot. Somebody will not get help with weight. They will not get help with their sleep. They will not get help, the more upstream help. They're told at their doctor's office, do all of these things. Let's see how impactful it is, and then we can talk about hormones. I think that is completely backwards. That I'll just leave it at that. Emily, I think, said it the best. That is completely backwards. While all of those things are integral to your overall health, that is not the place to start, in my opinion.
Okay, beautiful. You've really, addressed this to a degree, but I want to really make sure we answer every question as clearly as possible. So, how long does it usually take to start feeling better once when someone starts to get the right support?
Mm. So variable for sure. I so my personal approach is to look at the most bothersome symptoms first, because you really should only be starting one thing at a time, one medication at a time, one hormone at a time, and to be able to properly assess. So if you look at it that way and focus on the worst, most bothersome symptom or symptoms first, and
Mhm.
start with that particular next step, not to make promises because I know that this doesn't
Mhm.
happen to everybody, but I regularly see in the day-to-day practice, next day, 2 days, and maybe,
Amazing.
yeah, and it's not like a switch in it, you can feel, I hear all the time, like, wow, I wanted to go out and do things. Wow, I stopped crying. I stopped, yelling. I slept for the first night time. I wanted to go join my family in this outing that I haven't wanted to go do. So while that is very real and people feel a difference quite often very quickly if you've started with the right hormone, with that said, it continues to evolve, which
Mhm.
is amazing. It just, as your brain goes, okay, this is what we're doing now, it gets better and better and better, even without changing dosage. So immediate and then gradual, if that makes sense.
I mean, it sounds good to me, right?
Yeah.
That is wonderful. This is also more of a comment, but I think along the same lines, very, very encouraging. So, someone said, I did supplements and it wasn't enough. I kept them and then added in BHRT and focused on exercise and what I put in my mouth. Life changing. Dana is amazing, and is my provider. She was the seventh provider I saw, and I finally have hope.
Wow. Okay.
I'm sure you know who that is, but goodness gracious, seventh
I
provider.
believe it or not, I actually don't.
Okay.
I don't know specifically who that is because unfortunately I hear that all the time. Uh
Wow.
well, first of all, not everybody is educated and motivated, but being having to go to that many different providers, unfortunately, that is not a unique situation.
Seven feels like quite a few too many.
Yeah, my four were devastating. So I can't imagine what seven looks like. And
Hmm.
just to again, taking a side step over here, can
Hmm.
you imagine? So now I can't sleep. I'm going to go to this specialist.
Hmm.
I'm having heart palpitations, which by the way is a very common symptom. So I'm going to get sent to the cardiology. Um,
Hmm.
oh, my thyroid's starting to go out of range. So now I'm going to go see an endocrinologist. My joints hurt. Now I'm sent to a rheumatologist. And but women are not looked at with this
Hmm.
this umbrella of let's look at hormones. Symptoms in isolation is what the different specialties, how they're trained to care for women, and that's how a
Hmm.
woman can end up with seven different providers. Why not go kind of to the source, look further upstream, see how much of this could be hormones, and then if you indeed still
Hmm.
have these problems, then go see the specialist, not the other way
Hmm.
around.
Yeah. Yeah. Okay. Beautiful. When you talk about treatment options, this is probably very hard to do. Can you simplify how someone decides what's right for them?
Mm. Wow, yeah, I am not sure how to answer that.
Hmm.
I think we come into this phase of life with all of our history. Maybe our aunt is still telling us, estrogen's going to give us breast cancer. Maybe our primary still is thinking like that. Maybe folks don't want to ever take anything ever. And you know what? That's okay. But being able to look deep inside and recognize how much of our perspective is maybe influenced by things that should have less influence on us.
Hmm.
That's a long time ago and very misinformed when people were concerned about the safety risks of the types of
Hmm.
hormones we use today. So Gosh, how do they know? I think starting with a specialist and looking at history,
Mhm.
looking at where are you trying to go? What are your goals? You know, we just want to feel better, and might want to protect our long-term health. Sometimes those are, come in different stages. And what are my options? And then once a woman knows what her options are, sometimes then the pathway can become really clear. If say she's still like, oh, I'm not sure. I don't know what to do, but I just
Mhm.
want to feel better. Take a non-hormonal approach. See,
Yeah.
this is not a one-way street. And
Mhm.
actually, care is not going to be stagnant. As you go through this journey and your hormones change and change and change, your care plan's probably going to change. So, yeah, it's just what resonates with you. Every woman is an individual, and she deserves to make her own decision for what resonates with her. And knowing her options is the place to start.
Okay, great. Next one is it normal to feel less resilient than I used to?
What an articulate way to say that. Less resilient. Yeah, that is actually exactly what women experience, but sometimes have a hard time putting into words. So what I hear on a regular basis is, I have this amazing career. I have this job I love. I've got maybe I have kids. Maybe I have a family. Maybe I have a partner. Maybe I have, community involvement, these outside interests. And all of a sudden, I just can't do it anymore. I don't know why. I don't know what changed, but life is getting really, really hard. And to me, when I hear that, I hear the resilience piece. I can't go with the flow anymore. I just can't say yes anymore. And that is really common. And that is directly correlated to hormonal chaos, um, and hormonal slide into deficiency. Our hormones really, really protect us in that way, where we can, just juggle all the things of life. Maybe we do need to, pare down our life a little bit. And I can tell you, when you get to this stage, it becomes a lot clearer. We don't say yes as readily to things we don't want to do, but if we want to say yes to all those things and juggle all those things, then we want to be resilient. And that's where hormone replacement therapy, not just symptom management, but hormone replacement therapy can really help us become or feel like ourselves again.
Great. Question about essentially menopause and GLP-1s and where do those fit in together, or not at all?
Yeah, I love this question. GLP-1s, I prescribe them every day along with hormone replacement, or maybe not with hormone replacement. For midlife ladies, they are have like a synergistic effect almost. We actually have studies that actually say they have a synergistic effect. So going into midlife, one of the things that does happen to us, even if we don't change anything we've done, or if we're even working harder, sometimes I'm eating less, I'm working out more, and I'm still either gaining weight or can't lose weight, is this dreaded weight gain, and which is, if indeed you haven't changed things and you are, well, I'll leave it at that, haven't changed things, just to make it simple. Our hormone changes either cause us to be unable to lose weight, or to start storing more and more and more of this adipose tissue to help us hold on to hormones. So that is not just an aesthetic thing, which is what we often think of. Our clothes don't fit. I don't like how I look. That is a significant health risk, is when we get out of range. So that is where, in my opinion, where GLP-1s are a game changer, especially for midlife ladies. So they do a few things. Again, they have the synergistic effect. You never look at hormone replacement therapy as weight loss uh, medication, although it does help change our body composition when our body is not struggling so hard to maintain that homeostasis. So you add hormone replacement therapy, which then again, our bodies start functioning the way they're supposed to. And then top that off with a GLP-1, they just have this powerful synergistic effect to help us lose weight faster. which again, aesthetic, of course, but also improving our health during that time. And then they do a lot more than that. They can help with inflammation, and so many things. I know we all hear in the news all the new things that they're finding that it does for us. So GLP-1s are quite often, if a woman wants, part of the offerings in her care plan, and I think they are exceedingly impactful. I see them every day.
Wow. Okay. Can hormone shifts affect libido in more ways than just desire?
Yes, such a good question. So libido, when you think about it, is kind of in our heads. Just to oversimplify, we are complicated. We have to, feel, safe and desire. We want to desire, and we want all of these things. With that said, if we don't feel good, we don't feel the libido, that kind of sexual energy, with or without a partner. This is just that, energy, sexual energy. I don't know how else to say it. But it can be significantly impacted by the physical. So if sexual activity hurts, if sexual activity just doesn't feel the same anymore, or doesn't feel like anything, um, or it's just not functioning the way it's supposed to, they can be really hard to want to engage in it if it hurts and just nothing happens for us anymore. So, libido is a huge thing for most women in this stage of life at some point to some degree. It's always part of our conversation when we are talking about hormonal changes and options. But libido is a big deal. It changes for most of us. There is absolute help for it. I personally think that with or without a partner, it is just such a part of our essence as a human. Um, just for that zest for life, how we show up in the world with just this energy. It's not necessarily sexual, but it could be. So yeah, libido, there's a mental component, and there's absolutely a physical component, and there's many ways we can either improve it or sometimes just get it back to where it was.
So helpful. This is interesting. Can perimenopause mimic ADHD symptoms? I know, so this is me putting my 2 cents here. There's so much more awareness about ADHD now than there was, 5 years ago, 10 years ago for adults going, maybe I have ADHD. So really interesting question is, can perimenopause mimic those symptoms?
Yes, that is a really, really common thing that we see in our patients. And it is interesting. The changes back to that resiliency thing. I can't think straight. I can't keep track of things. I can't focus. Some women do have undiagnosed ADD, ADHD that now the mask has come off because hormones are just not protecting her anymore, and this needs to be addressed as a separate diagnosis. But and that's very real. A lot of women can really manage that, but then when that resiliency is gone, she can no longer. So maybe she does have that, and it's just been undiagnosed. Or just as often, or probably more often, it's just the way those symptoms present, and they look like ADD or ADHD. So it could be hormonally related that would correct once the hormones were addressed.
Okay,
Very, very, very common.
very common. Okay, good to know. Um,
How
well,
how are we doing on time? Because I think
yeah,
we're over.
yeah, it is completely up to you where we go. So we plan to go to 11:30. We've hit that.
Yes, I like to be mindful of people's time.
Yeah,
I do that with our patient appointments as much as I can.
yeah. Okay, beautiful. Thank you so much, Dana. I'm really looking forward to getting to work with you as soon as finances allow. This was such great info.
Awesome, awesome. Well, I really hope to see as many people as possible. And if I can't be your provider and your specialist to go walk this journey with you. I really hope I've given you some food for thought to go find yourself somebody who will be your partner during this, that you can get the very best care that's out there and that's possible. And we're always here too. So if you want to send any questions that we can help with, maybe we can, we would love to hear from you. But thank you everybody so much for showing up. I'm still just overwhelmed with how many of you are out there, and I'm here for you.
Thank you, Dina. That's so amazing. Thank you everyone for coming.
Bye everybody.
The replay will go out Monday. So if you want to listen again, because I know this is a lot of info, you will get it on Monday.